This is a great challenge to try to understand how to treat this complex group of patients. So what I'm going to do today is share with you an approach I've developed from a primary care standpoint. I'm not quite a primary care clinic, but I'm an internist, and my approach, I have a fatigue clinic. So when patients come to see me, they've been screened for most of the obvious things, and then it's my job to try to sort out. And among that, I would say that about 75% of my patients meet criteria for fibromyalgia, and probably 50 to 60%, and there's a lot of overlap, meet criteria for chronic fatigue syndrome. And that idea about whether or not they have another illness that's contributing to their symptoms is a complex one, because you can certainly meet criteria for chronic fatigue syndrome and then develop other illnesses on top of it. So I have an approach that I've developed, and if it's helpful to you, that will be great. And it's a very practical approach. I'm going to talk about three main thrusts. The first is an effort to diagnose and treat every comorbid condition that you can identify. That gives you something to do for a really long time. Second is to prioritize and treat the major disabling symptoms, but revisit diagnosis and economize medications. So that means when you get stuck and you don't think you have any more comorbid conditions to address, start looking at what are the most disabling symptoms. Think about the symptom, return to the diagnostic paradigm, but start to compensate that symptom. But don't pile on so many medicines that pretty soon people are on 50 meds, and believe me, I've done that many times. The last thing is this balance of pacing activity versus preventing deconditioning, and this is something I try to incorporate in every visit, and we'll talk through these. So I want my black box warning before I start to remind you that there are no FDA-approved drugs with an indication for CFS or fibromyalgia, for that matter, right now. So strictly speaking, everything we use to treat the symptoms are used off-label, but they're really not, because when you identify a comorbid condition, you can treat the comorbid condition with drugs that are used for that indication. But I think we need to keep in mind that we're not necessarily treating the primary problem, which we still need to understand better, and why we need more research about these illnesses. Ampligen is one drug that may become available for CFS, and it's pending approval, FDA approval, and I'll be talking about some drugs that are pending FDA approval for the treatment of fibromyalgia. I also believe that as we understand subsets better and we delineate them using objective measures, we're going to be able to direct treatment more specifically at those subsets, and I think we should keep that in mind. Few therapies thought to be helpful have been tested in double-blind, placebo-controlled trials, including those I'm going to be discussing. So remember, I'm expressing my own opinions, and the things that I say here, I'd really like you to experiment on your own and use your own judgment as you approach treatment. I want you to keep in mind this complex relationship between dealing with comorbid conditions and just addressing symptoms, disabling symptoms, and going back and forth in your paradigm between trying to make a diagnosis and nail down comorbid conditions versus just treating. This is a slide we could spend about 2 hours on. This is a list I would make as very common comorbid conditions in my patient population. This is after you've done your screening lab tests and the obvious things to look for underlying conditions. And this is a list I can return to over and over in my second tier, my third tier, my fourth tier approach to trying to understand patients. Orthostatic intolerance syndromes, I'm going to talk a little bit more about specifically. We've heard about sleep disorders. I can't emphasize how important it is to continue to understand what's going on with your patient's sleep, because that is the primary treatment intervention, and your success is going to depend on treating the mechanisms that are disturbing sleep. Secondary or atypical mood disorders constantly return into the management of your patient. And when you have a friendly relationship and an open relationship with your patient, you're going to be able to discuss mood disorders. They get that stress triggers mood disorder, anxiety and depression. And then also as you get to know people, you may understand more about their underlying biochemistry and how the way they approach the world may impact their disease. Allergies, chronic sinusitis, reactive airway disease. This is sort of an underlying secondary condition that we can hammer away at. bowel disease, just, when that symptom comes to the top of your list, irritable bowel symptoms, you need to go back to that diagnostic paradigm, start thinking about atypical syndrome, start thinking about lactose intolerance, work your patients up for celiac disease. When you come back and separate out the symptom and start thinking diagnostically again, you can dig deeper and come up with things that will take a chunk. Usually, my experience is that addressing any one of these things is not going to cure your patient. These are comorbid conditions, but what these do is empower you. And they also empower your patient. For me, as you complete a careful diagnosis, give your patient a close look, include them in the discussion, and give them tools for teasing apart their symptoms and starting to impact their symptoms, they're going to gain a sense of control over their illness, which is huge. When you start to feel like you can impact this symptom or that symptom, that person comes back in control and becomes the captain of their ship, so to speak, and becomes more empowered in managing their illness. Focal pain conditions we're going to talk about. I'm not going to take time to talk about metabolic syndrome, but I did a quick look at my male patients in my clinic, and 50% of them met criteria for metabolic syndrome. Most of those patients had horrible pain conditions, and that question of whether or not it's primary or secondary is a very interesting question, but it's irrelevant to management. So identify metabolic syndrome and treat it aggressively. If you're not quite sure how to do that, get into the literature. I always start with non-pharmacologic interventions and work on diet and activity level and reducing people's body fat and engage the patient in an understanding of metabolic syndrome and how it might affect their illness. I've had patients come in horribly tired and achy, and all they had was metabolic syndrome. And when they changed their diet, increased their activity level, even before the weight came off, that horrible inflammatory condition, that whatever that metabolic condition is, when reversed, the energy level increased and the pain melted away. So I know that it has to be an important comorbid condition when in some patients it can be the only thing that's driving their symptoms. Think about hormonal balances or dysregulation. Always be thinking about chronic or recurrent infections. I had a patient from Idaho who came down to see me who, I don't know why I thought of it, he'd been treated for chronic fatigue syndrome for years. And actually his illness was diagnosed before we had a test for hepatitis C. And I went ahead and added a hepatitis C, and he had chronic hepatitis C. So, revisit the idea of underlying chronic infections if they haven't been addressed. We check a vitamin D level in all of our patients now. I'm amazed at how many patients have low or low normal vitamin D levels. Nancy mentioned this yesterday. And we screen for vitamin B12 deficiency. We don't want anyone. If we're talking about patients having a central nervous system condition, a pain condition, why would you ever want people's B12 levels to drift down and put them at risk for cognitive or peripheral cognitive symptoms or peripheral neuropathy or the horrible neurologic consequences of low B12? And when it occurs in conjunction, it may, with other illnesses, may be even worse. I have a patient who had well-documented EBV, he's an adult, that he developed mono when he had undiagnosed, quite severe B12 deficiency. And he became so ill and developed such a severe peripheral neuropathy and then remained chronically impaired even though all of those things were corrected. And I'm quite sure that the combination of those two illnesses made his illness much worse. And then deconditioning. So that's just a list. If you want to, this is a list that I have that I go back to over and over and over and over as my patients come back in and we revisit each one of those. And there may be others on your list, but these are common themes in patients who come to the clinic. So what about an approach to treating symptoms? We're not trained to treat symptoms, especially in internal medicine. We're trained to avoid treating symptoms. Always know what you're treating. But the fact is, we can't do that necessarily. So I think that there's a way to have a respectful approach to treating symptoms. And this is my hierarchy of addressing symptoms. I think about sleep first, mood, and pain. This is my big triad, is coming back to sleep, mood, and pain. Fatigue, we'll talk about how I put that in the hierarchy. Pacing and conditioning, and orthostatic intolerance. And then I always come back to, am I micromanaging? Am I managing all the other medical problems of this patient? So that's how I address symptoms. And I use a table, the legs of a table, to remind me about these things. The mood, sleep, pain, and fitness are the legs of the table. And fatigue is like the surface of the table. You really have to come about fatigue indirectly by managing the other symptoms. And if any of those are imbalanced, the table tips and the fatigue becomes worse. So I want to talk about it from that standpoint. So first, sleep. There's many ways to address sleep. Sleep hygiene, behavioral modification. You definitely need to seek the cause of sleep disturbance, and then you need to choose, if they need medications, choose medications in the context not only of the cause of their sleep disorder, but in the context of all their other symptoms. So if you have a very overweight patient battling metabolic syndrome, you wouldn't want to put them on a drug that's going to cause weight gain. If they have serious postural orthostatic tachycardia syndrome, POTS, you would want to be careful about putting them on a tricyclic at night that would increase their heart rate and increase their orthostatic intolerance. So when you choose a medication, you need to do it in the context of the rest of the symptoms. And I want to say that, we know that natural sleep is best, but chronically abnormal sleep is insidiously harmful, as we've heard. And when patients have disturbed sleep, they develop fatigue and pain syndromes. So although there's no perfect medication for sleep, sometimes we have to use them, and almost all have some adverse effects that come along with their use. So my approach to sleep disturbance, I won't take a lot of time, but this is my approach. Reduce things that might disturb sleep, teach people about sleep hygiene, definitely look for this activation, the sympathetic activation, restless legs, movement disorders, definitely treat obstructive sleep apnea. Think about what you might do to improve central sleep apnea. Make sure that you're supporting all these underlying things before you just try to medicate sleep as a symptom. On the other hand, once you've done your work, you still have to help your patients sleep. And I'm just going to put up here that people say to me, what do you do for sleep? Well, there's a lot of medications. I probably use almost everything out there a little bit, because I try to tailor it to all those things, try to learn about what the sleep disorders in the patient. Sometimes people just need sleep initiation, and they can get to sleep, they can sleep the rest of the night. Sometimes people have something going on all night long that's disturbing their sleep. So here's some of the sleep initiators and sleep sustainers. And you can see there's really a large array of medications that can be used for sleep. And what I might do is try to pick something that treats multiple problems. So if someone has cord compression and fibromyalgia, I might want to try something for sleep, and one of the anticonvulsants that will treat their nerve pain, kind of calm them and help them sleep through the night. And hope that we can find some kind of a medication that treats multiple things and achieves that restful sleep during the night. The next thrust, the next leg of the table is really thinking about mood, and I really should put mood and cognition in one, just thinking and mood in one category. And there's a lot of ways to support that. You can talk, Stuart's going to talk a little bit about supportive counseling, thinking about stages of recovery, where people are mentally in living with a horrible chronic illness. We treat mood disorders with standard approaches, but we should choose medications in the context of the other legs of the table. So when you choose something to treat the mood, make sure it's something that's not going to tip your table, something that's not going to disrupt sleep or create more pain or contribute to deconditioning and orthostatic intolerance. How do we go about treating mood disorders? I've just diffused that question of primary or secondary, and you come in, you have a good discussion with your patient. If they have anxiety or depression, we talk about it, we address it, and we work through standard channels. That whole question about, I agree totally with Andy, that whole question about anxiety, these upregulated disorders, ADD, PTSD, anxiety disorders versus autonomic dysfunction. The question is really how can you address the symptom, calm the symptom, and achieve the kind of a clinical result you want without causing too much undue side effects from your medications. Just a word about bipolar disorder. The clinical, in my clinic, I think a significant portion of patients probably have a bipolar type biochemistry, let me say. Sometimes they aren't formally diagnosed. To me, making the exact diagnosis is not important, it's using it to lean toward the kind of medications that I choose, we use mood stabilizers as pain modulators and as medications to help sleep. So if you suspect someone has that kind of a biochemistry, that kind of behavior that you might look at as borderline or as a bipolar disorder, choose mood stabilizers to treat their pain and to help their sleep and to augment their antidepressants is very successful. Just thinking about what kind of a mood disorder this person might trend toward. And don't overtreat the mood disorder trying to cure the CFS or cure the fibromyalgia. Sometimes we overuse the medications, push the doses too hard. I think just having a conversation with your patient, letting them be part of the treatment plan, having them give you feedback about the medications is tremendously helpful. So the next leg of the table is pain. And this is something I like to go back to over and over. Once we have a pain diagram and we're dealing with fibro or CFS, sometimes we lump pain into one big bag and we stop thinking about focal pain syndromes. So I like to, every time pain comes to the top of the list, I start to go back to that go back out of symptom management into the framework, the mindset of cause. Think about what might be driving the pain. Help restore a sense of control to the patient about management of their pain. Choose your medications in context and avoid tipping the table. So we use pain diagrams and visual analog scales every visit in my clinic, and we just, every single visit they come, I take the highest, whatever the highest numbers are, that becomes the focus of conversation of our clinic visit. So if their pain is highest or their mood is highest or their sleep is highest, I address the visit from that standpoint. Think about how it interacts with the other things. I always review the med list and think about whether or not we have to go back to a diagnostic approach, adjust the medicines, or add something new. I use pain diagrams because at a glance, those of you, who are clinicians in the audience, you can tell the difference between polyarthralgias with myalgias, peripheral neuropathy, and other kinds of widespread pain, and you can look for asymmetry in pain so quickly with a pain diagram. And anytime there's asymmetry, as Dr. Holman suggested, you need to think about focal causes of pain. If they've got pain in one place, people don't realize, unless you ask, they don't realize that focal pain is something you need to think about. They'll say, my pain is terrible. And I always say, well, which pain? Tell me about your pain. And go back to the pain diagram, because if they've got a pain in their shoulder going down their arm, or they've got a pain, in their foot, and that's their fibro pain, you're going to have a completely different discussion if you don't know what pain you're dealing with. There are many focal pain syndromes that occur under the umbrella of the cases we're discussing. It's really nice to know if they're talking about joint or muscle pain. Osteoarthritis as a comorbid condition is so much more treatable than the pain we're dealing with. And it's nice to know if you can address their osteoarthritis either with anti-inflammatories or with injections or focal procedures or surgery. I always work up cervical and lumbar disc disease. I haven't done those extension views, and I think it's a great idea, but for me, what I do is is the nature of their symptoms and their response to their medications implies, helps if they've got more of a neurogenic pain syndrome versus an inflammatory pain syndrome versus allodynia, that's the surface of their skin, and if you take a careful history, you can make an intelligent choice about the kind of medications and interventions you use. Certainly TMJ, we have many drugs for treating migraines. Migraine prevention, I can tackle migraine prevention. It's much easier to treat than chronic fatigue syndrome. We can deal with, think about what might be going on in their bowels, and you can address carpal tunnel syndrome. You can inject bursa and joints. And peripheral neuropathy, if you don't ask the right questions, you'll miss peripheral neuropathy. You need to do a diagnostic workup to think about causes. And then we have pretty effective drugs. And there's some of the drugs on the list that we use to treat pain syndromes. Okay, the last leg of the table is really fitness, deconditioning, which I always separate into flexibility, strength, and cardiovascular conditioning. And then I've lumped up there obesity and dealing with orthostatic intolerance. It's so important to remember that pacing, this is my opinion, the single most important thing a patient can do to improve their function is to learn how to pace their activity level. I think it's more important than anything I do for them. And I think patients understand that. They need to be validated. On the other hand, the flip side of that is that activity limitation results in deconditioning. And if you talk about deconditioning to a patient, they get it. I say, what happens when you put your arm in a cast for 6 weeks? They all remember what that looked like in grade school when their colleagues got their cast taken off and their arm looked like a wet noodle. And, a person's conditioning level is going to sag to whatever their daily level of activity is, whatever their average daily activity level is. So we talk about ways to, within the context of their illness, start to improve their conditioning level, and sometimes starting at very, very low levels. I just wanted to throw in a couple of slides. We don't have a lot of time, and I want to talk about the medications, but these are studies done by researchers at the University of the Pacific on patients with chronic fatigue syndrome. And what I wanted to point out is they separated the patients into 4 groups: no impairment on the left and severe impairment on the right. And if you want to compare some of those values, you'll see that their ability to achieve a VO2 max, or an oxygen consumption, as shown as a percent of predicted, it was 80% in the no impairment group, over to, and this is no impairment on cardiopulmonary testing, over to severe impairment, only 38% of predicted. And then I think it's interesting that their ability to achieve a heart rate and bump their systolic blood pressure actually got worse, lower, the more impaired they were. And this hasn't really been explained. But there's something, very wrong physiologically with patients with chronic fatigue syndrome, and we need to be careful. I mean, think about a deconditioned person. When you put a deconditioned person on a treadmill, what happens? The more deconditioned they are, the more their blood pressure goes up, and the more their heart races with exercise. These numbers from CFS patients, these are patients engaged in the Ampligen clinical trial, are very surprising. And as you can see, their BMI across the top is about the same. This doesn't relate to obesity. And if you'll look at the RQ peak, which is a measure of them achieving, getting to an anaerobic metabolism right at that level where they achieve a test of significance, was about the same across the board. So these patients all exercised at about the same intensity and were unable to mount this cardiovascular response that we would see in people who are just deconditioned. And they also did a test where they did cardiopulmonary testing 2 days in a row, one day and the next day. And you'll see that the CFS patients, compared to controls, were really unable to replicate their oxygen consumption, and here it is in graphical form. This is just a way of demonstrating that post-exertional malaise. And we saw a little bit when we heard from the lights yesterday, maybe getting at some of the physiology of that. But physical conditioning, it can be done, but it has to be done with compassion and with a lot of communication. But there are many, many aspects to physical conditioning that will help the patient. They're more able to function, they don't fall as much, it improves sleep, it helps their mood and self-esteem, it helps them maintain their weight, but it must be completely adapted to the individual. And what I tell patients is you can exercise to the point of relapse, but do not extend your exercise to the point where you have relapse symptoms the next day. And that's sometimes difficult, and sometimes that means doing just 5% more than what their regular activity would be during the day. And I focus on flexibility first, start them on stretching, a little bit of toning, some resistance activity, and the most difficult thing usually for CFS patients, a little easier for fibro on a spectrum, is getting their cardiovascular conditioning so they can, and maybe it has to do with orthostatic intolerance or other aspects of physiology. So what about treating fatigue directly? Sometimes, and sometimes, these are probably the 4 medications I use most frequently, but I don't even approach direct treatment of fatigue until I've done all those other things. When I know my patient well, we've established their sleep, I have a good handle on what's going on with their mood, and then sometimes, and Wellbutrin really can go in that category of treating mood and cognition, but I use a little of Provigil, and I sometimes use short-acting Schedule II drugs or long-acting, and I just think they have to be used with care, and they can be incredibly helpful. Patients can't wake up in the morning, they can't get going. Sometimes a little bit of something will kind of click that brain on, increase their energy level. Those drugs have other actions that we don't know. I don't find them problematic. They're a little more hassle for a physician because they're Schedule II, and you need to monitor them, and patients have to come in more frequently. That has to be an individual decision by a practitioner, and they should be followed closely. I tell my patients, as long as you don't have anxiety, it doesn't increase your anxiety and irritability, and as long as it doesn't come anywhere near your sleep, and you can report to me how these medicines benefit you, I'll let them use them and give them the choice. And many times people come back and say, half or more of the time, nope, that's not for me. I don't like the way I feel on that medicine. and then we go another direction. I'm not going to say too much about orthostatic intolerance. I try not to over-treat it, but I like to be aware of it. I think the most important part of orthostatic intolerance is helping people understand what to do behaviorally, how to take in fluids, how to not spend a lot of time standing, how not to get overheated. I treat it pretty aggressively in adolescents because they have so much more autonomic instability, and it gives them something to work on. I use proamotine, midodrine quite a bit, if I got my drugs here. Yeah, you know, I try to use fluid and sodium loading carefully. I use Florinef a little bit. Sometimes studies have shown that after a while it really doesn't give much benefit, and I think it has to do with downregulation of the HPA axis myself and the complexity of this illness. I use midodrine quite a bit for young people because our people who want to be physically active. It's short-acting, it's a peripheral alpha agonist, it causes just enough constriction to raise the blood pressure, and I combine it with bolus oral fluids, and it gives people several hours of ability to be upright longer without relapse symptoms. But it requires a great deal of compliance because it's so short-acting. Sometimes I use beta blockers, but you know, I think this is something you can pursue, but again, you have to do it in context of the rest of their medical problems. And it's not something you can do in someone who's older with metabolic syndrome and hypertension. And sometimes people don't tolerate sodium loading. So it's just problematic. Communicate well, prioritize symptoms, economize the use of medications, and remember that the presence of a symptom does not necessitate treatment. Sometimes patients just need to know that their symptom is not going to hurt them or be dangerous. And I think sometimes we forget to ask. You know, we're talking about the symptom, and I'll say, you know, how are you doing with that symptom? Do you want me to do something about it? And they'll say, no, I'm doing fine, even though it was innate. But they feel fine. They have confidence. They know they can deal with that symptom. And sometimes we need to resist the temptation to add more drugs or do something if they feel like they can manage a symptom. I just wanted to throw on here, and you can refer to this yourself. This is my own chart of how I might approach the use of these many medications out that we can use for pain modulation and sleep. And what I've done is group them by type and put my own stars. These are not from the literature, okay? These pluses are from my clinical experience of how I think they impact sleep, mood, pain, and migraine, what I think are the main downsides of using these medications. You can see from this slide, if you just want to look at sleep, if people are having sleep problems, I'd go to the 3- and 4-star medications and then tailor it to the cause of their sleep disorder if I can, and choose the medications that I think will work for multiple things. Same with mood. If you look on the migraine list, there's, I have a couple of favorites. I use Topamax and Depakote, depending on someone's weight status. And you just need to start carefully. When people have obesity problems, I like to choose, I really love using Topamax and Zonegran, topiramate and Zonisogran. These are medications that if used very carefully, you need to start them low, work them up gradually, follow your patient, can be very helpful as mood stabilizers, as pain modulators. Sometimes they help downregulate people for sleep, and they are very useful drugs for patients who also have comorbid metabolic syndrome. I've had patients that we started on either of those drugs who came back a year later and were 30 pounds lighter without much strong intervention. That if they're following the rest of the paradigm, which is their exercise and following a diet, their weight will start to drift down on those medications. And those are medications that have a significant number of side effects and interactions, so you need to understand your medications and decide how you're going to use them carefully. So these are my general principles of management. Diagnose and treat comorbid conditions, not just at the beginning, but think about them in the back of your head every time you see your patient. Prioritize and treat major disabling symptoms. So once you've done the job of comorbid, you can address the symptoms, but it should send you back to a paradigm of thinking about diagnosis as well as treatment. Always try to economize your medications by using medications that treat multiple things. And then every visit, I have a discussion with my patients about pacing compared to deconditioning. And it's just like the advice we got as physicians for smoking cessation. As an internist, I was taught if you talk to your patient every visit about smoking, it's going to make a bigger difference than any other intervention. So now I just talk to my patients every visit about what they're doing to help their own deconditioning. And I am so pleased because they come back and they tell me what they're doing, and almost every patient has made progress in their deconditioning. So hopefully that's helpful, and we can spend a little more time talking about it in the cases. Thank you.